These great surgeons take care. Upper limb, just like all the anatomy chapter, they are overlapping with many chapters. They are not only 6 questions in the exam, because especially the limb question is overlapping with ortho and trauma. It's good news by the end of your study, by the way. It's not bad news. It might be confusing at first if you are not orthopedic or not plastic, and mainly the general surgeon will face some trouble with the upper and lower limb because they tend to skip it during their pre-graduate schedule study. So you will be familiar with them with time, and you will find it a good privilege to have in the exam more than 60 questions in upper limb and lower limb. These great surgeon. A common question in the exam is about the shoulder abduction. It's carried out with the supraspinatus, the deltoid, serratus anterior, and the trapezius upper and lower fiber. The supraspinatus is the initiator of the abduction of the shoulder from the angle from 0 to 15, while the deltoid carried out the abduction of the shoulder from 15 to 90. From 90 to 180 is carried out by the serratus anterior and the trapezoid. Take care. In our carpal bone, we have trapezium, triquetrum, and trapezoid, but the trapezius is a muscle. It's not a bone. Take care. Dear great surgeons, carpal tunnel questions in the exam is very important. You have to be familiar with the carpal tunnel syndrome and the carpal tunnel content and surface anatomy. The carpal tunnel contains 9 flexor tendons: the flexor digitorum profunda, the flexor digitorum superficialis, and flexor pollicis longus. But here he is asking about the closest proximity to the hamate bone. So let's think the tendon of the flexor digitorum profunda lie deepest in the tunnel and will thus lie nearest to the hamate bone. This is a whole trick. A very common trick in the exam regarding the ulnar nerve. Remember, the ulnar nerve is not within the carpal tunnel. The ulnar nerve has its own canal in Guyon's canal. These great surgeons always remember that the artery is deeper to the nerve. So the nerve is like it's guarding the artery. So now you can solve the puzzle. The ulnar nerve is outside and the ulnar artery is inside, while the radial nerve is outside and the radial artery is inside. You can now solve the puzzle and figure it out. Put your bones and put which is which. Hope this made it simple. Again, the ulnar nerve is ulnar to the ulnar artery, while the radial nerve is radial to the radial artery. The nerve guards the artery. You have to hide your supply. The blood supply is deeper than the nerve. Dear great surgeon, remember the cephalic vein penetrates the clavipectoral fascia prior to termination in the axillary vein, and the cephalic vein is favorite vessel for arteriovenous fistula formation and should be preserved in patients with end-stage renal failure. Dear great surgeon, a fall onto outstretched hand is common mechanism for injury of scaphoid fracture. This should be suspected clinically if there is a tenderness in the base of the anatomical snuff box. A tender rupture would not result in a bony tenderness at all. Regarding the scaphoid fracture, you have to put the patient initially in a futura splint and reassess with X-ray if the X-ray is showing no fracture, and reassess this X-ray after 1 to 2 weeks. And by the way, a common question regarding the scaphoid bone fracture is regarding the blood supply. It's yes from the radial artery, but it enters the scaphoid bone from the distal part. This is a very common recall questions by the exam. So take care. The lunate lies medially in the anatomical plane of the scaphoid. So the fracture of the scaphoid are associated with high velocity injury that may cause associated lunate dislocation. Just look at the illustrations and you will understand it all regarding the relation between the lunate and the scaphoid. So take care. The scaphoid blood supply is very important to know that it's from the distal end, and if it's not shown in the X-ray, you have to suspect it because this will lead it and make it prone to non-union, because the blood supply is from non-articular surface near its distal end, and the transverse fracture of the scaphoid will carry a risk of non-union. That's why this question is very important to be suspected, even for trauma surgeons, orthopedic surgeons, and plastic hand surgeons. Always take care from what you have to do now and what is the definitive treatment and what is the initial to be done. When he tells you a scenario about a builder falls from a scaffolding and lands on his left hand and suffering from severe laceration to his palm and x-ray showing evidence of scaphoid fracture with minimal displacement, so you have to do initially admission and surgical debridement, because technically this is an open fracture and should be debrided prior any attempt of succession, which should occur soon after that. And remember, scaphoid fracture, 80% of carpal fracture and 80% occur in men and 80% occur at the base of the scaphoid. Dear great surgeons, we have 3 nerve signs important in our exam: the Phanen sign, the Phanen sign, and the Tunnel sign. So, Phanen and Tunnel for the Carpal Tunnel syndrome, while the Phanen sign for ulnar nerve palsy. Phanen sign is important in your clinical examination for hand injury, and it will exclude or include ulnar nerve palsy, because it will assess the adductor pollicis, which is the only muscle in the thenar group which is supplied by the ulnar nerve, because the whole thenar muscle is supplied by the median nerve except for the adductor pollicis longus. So, the adductor pollicis muscle function is tested by the Phanen sign, where we give the patient and make him hold a piece of paper between his thumb and index finger. The object is then pulled away. If the ulnar nerve palsy, he will be unable to hold the paper and will flex the flexor pollicis longus to compensate flexion of the thumb at the interphalangeal joint. So this will indicate that the patient has ulnar nerve palsy, the Phanen sign, while the Phanen test is assessing the carpal tunnel syndrome and more sensitive than the tunnel sign. You will make the patient to hold his wrist with maximum flexion and test the positive if there is numbness on the median nerve or not, while the tunnel sign is to assess the carpal tunnel syndrome by tapping the median nerve at the wrist, and the test is positive if there is a tingling or electric-like sensation over the disruption of the median nerve. Hope this made those signs clear. So, Phanen sign for ulnar nerve, Phanen and Tunnel for median nerve. These great surgeons, we all know the Palmaris Longus, and we all know that the Palmaris Longus is an accessory muscle that might be absent in many humans. About 10% doesn't have the Palmaris Longus, and it's very famous for tendon graft sores. But many don't know the Palmaris brevis. The Palmaris brevis is one of the intrinsic muscles of the hypothenar muscles, and of course the hypothenar muscles are all supplied by the ulnar nerve. So the trick in the exam will be asking you about the Palmaris brevis nerve supply. It's supplied by the ulnar nerve, while the Palmaris longus is supplied by the median nerve. So a famous question will ask you, all of those are supplied by the median nerve except, and will be the Palmaris brevis, or he will ask you which muscle of those is supplied by the median nerve, and he will state the Palmaris brevis in other muscle group, like the second, third interosseous and the adductor pollicis and the adductor pollicis longus, all of those by the ulnar nerve, while the abductor pollicis brevis and the Palmaris longus are by the median nerve. Hope this made it clear. These great surgeons, the anterior interosseous nerve is a motor branch of the median nerve, just below the elbow. When it's damaged, it classically causes pain in the forearm and loss of the pincer movement grip with the thumb and the index finger, And this is due to innervation of the long flexor muscle of the flexor pollicis longus and the flexor digitorum profunda of the index and middle finger. And there will be a minimal loss of sensation due to lack of cutaneous branch. Dearest great surgeon, take care. The median nerve, when injured proximal to the flexor retinaculum, will result in loss of the flexor pollicis brevis and the opponent's pollicis, as well as the first and second lumbricals. When the patient is asked to close the hand slowly, this will cause a lag of the index and middle finger, reflecting the impaired lumbrical muscle function. The sensory changes are minor and will not extend above the dorsal aspect of the senior eminence, while the abductor pollicis longus will contribute to the subabduction and is innervated by the posterior interosseous nerve, and therefore abduction will be weaker than prior to the injury. Dearest great surgeon, the muscle innervated by the musculocutaneous nerve are PBC, biceps brachii and brachialis, as well as the coracobrachialis. So, PBC, musculocutaneous nerve, supply biceps brachii, brachialis, and coracobrachialis. So we have agreed on that the muscle innervated by the musculocutaneous nerve mnemonic is PBC, biceps brachii, and brachialis, as well as the coracobrachialis. But take care, the musculocutaneous nerve arises from the lateral cord of the brachial plexus, and it provides cutaneous innervation to the lateral side of the forearm. Those are important notes regarding the musculocutaneous nerve. Dearest great surgeons, the radial nerve is very important because it's a continuation of the posterior cord of the brachial plexus, root value from C5 to T1, and its path is a common question in the exam. But let's take care of the mnemonic of the nerve supply muscle. It supplies the best muscles. What are the best muscles innervated by the radial nerve? To make it simple, they are the muscles of extension, the brachioradialis, the extensors and supinator, as well as the triceps. The radial nerve is responsible for innervation of the extensor compartment of the forearm, and it's overlapped by the medial and the ulnar nerve. That's why the sensory loss in radial nerve injury is not that much. It only causes like a coin in the snuff box of the hand dorsum. Let's revise together the radial nerve pathway. We all agreed that its root value from C5 to T1 from the posterior cord of the brachial plexus. The radial nerve from the posterior cord of the brachial plexus C5 to T1. In the axilla lies posterior to the axillary artery on the subscapularis and latissimus dorsi, as well as the teres major. It enters the arm between the brachial artery and the long head of triceps, medial to the humerus, and spirals around the posterior surface of the humerus in the groove of the radial nerve. At the distal third of the lateral border of the humerus, it then pierces the intermuscular system and descends in front of the lateral epicondyle. Again, in front of the lateral epicondyle. At the lateral epicondyle, it lies deeply between the brachialis and the brachioradialis, where it divides into superficial and deep terminal branches. The deep terminal branches crosses the supinator to become the posterior interosseous nerve. And the posterior interosseous nerve supplies the extensor carpi ulnaris, extensor digitorum, extensor indicis, extensor digiti minimi, extensor pollicis longus and brevis, as well as the abductor pollicis longus, while the main radial nerve itself supplies the triceps, the anconeus, the brachioradialis, and extensor carpi radialis. So all the extensors by the posterior interosseous branch except for the extensor carpi radialis. And of course the triceps, anconeus, and brachioradialis, as well as the extensor carpi radialis by the main nerve of the radial nerve. And again, regarding the sensory innervation, the area of the skin supplying the proximal phalanges on the dorsum aspect of the hand supplied by the radial nerve. This doesn't apply to the little finger and part of the ring finger as well. Take care. The abductor pollicis longus is supplied by the radial nerve, and to be more specific, by the posterior interosseous branch of the radial nerve, the abductor pollicis longus, while The abductor digiti minimi has nothing to do with the radial nerve, neither to the interosseous branch. The abductor digiti minimi is part of the hypothenar muscle, so it's supplied by the ulnar nerve itself. Dearest great surgeon, take care. A very tricky question regarding the transaction of the radial nerve or radial nerve injury at the level of the axilla. It will result in loss of the elbow extension and loss of the metacarpophalangeal extension, and as well as the loss of triceps reflex, and will loss of sensation overlying the first dorsal interosseous. But take care, there will be preservation of the extension of the interphalangeal joint, because the patient will still extend the virtual retained lumbricals action and can extend his interphalangeal joint via the preserved lumbrical, which is supplied by the ulnar nerve and the median nerve. So, take care from this tricky question. So, regarding the lumbrical muscle, they are named such name like lumbrical because they are elongated worm-like form, and they are originated from the flexor digitorum profunda, by the way. So if you want to differentiate between the flexor digitorum profunda and flexor digitorum superficialis in the hand, you have to know that the flexor digitorum profunda muscles in the hand are the lumbricals, while the superficialis has no muscle attachment. So the tendons with muscles are the FDP, the flexor digitorum profunda, and the lumbricals are inserted in the lateral side of the extensor expansion of the digits 2 to 5. The action is to flex the metacarpophalangeal joint and extend the interphalangeal joint. Very important and very tricky question. So again, if the radial nerve was severed or injured, the extension of the interphalangeal joint will be kept by the action of the lumbricals. The interphalangeal joint, not the metacarpophalangeal. The metacarpophalangeal joint will still be flexed, not extended, while the interphalangeal joint will be extended. So your finger can be extended, but the metacarpophalangeal joint will be flexed. So the radial nerve is anterolateral to the lateral epicondyle, while the ulnar nerve is posteromedial to the medial epicondyle. Dear great surgeon, a very tricky question asking you about an old man presented with arm weakness, and on examination he has weakness of the elbow extension and lots of sensation on the dorsal aspect of the first digit. At this site, what is the most likely underlying defect? Take care. The radial nerve is the answer. But to understand this question, you have to know that the long head of triceps may be innervated by the anterior nerve as well as the radial nerve, and therefore complete loss of the triceps muscle function may not be present even in the proximally sited nerve lesion of the radial nerve. Here again, the MRCS question tracking you regarding the Palmaris brevis. The Palmaris brevis is one of the hypothenar muscles which is supplied by the ulnar nerve, while the Palmaris longus is supplied by the median nerve, and it's a common site for tendon graft. And this reminds us that the flexor carpi ulnaris and the median half of the flexor digitorum profunda is supplied by the ulnar nerve, while all the flexors of the hand, all the flexors of the forearm is by the median nerve, and all the muscles of the hand almost by the ulnar nerve, except for the thinner, except for the adductor pollicis, which is supplied by the ulnar nerve, and the lateral lumbricals, which supplied by the median nerve as well. This reminds me that all the extensors of the hand is supplied by the posterior interosseous, except for the extensor carpi ulnaris by the radial nerve itself. A very funny mnemonic regarding the ulnar nerve, it supplies the mafia. The ulnar nerve is a mafia nerve. It supplies the medial lumbricals, the adductor pollicis, the flexor digitorum profunda, and the flexor digiti minimi, as well as the interossei and abductor digiti minimi and opponents. The mafia is supplied by the ulnar nerve. So, it innervates all the intrinsic muscles of the hand except for the thenar muscle and the first two lumbricals supplied by the median nerve, not the ulnar nerve, while the pronator teres is innervated by the median nerve. The palmaris brevis is innervated by the ulnar nerve. The palmaris longus innervated by the median nerve. The longus medius, the brevis ulnar. And the median is bigger than the ulnar. So the longus will be the median, while the brevis will be the ulnar. And remember, the ulnar nerve origin is C8 to T1. This is the root of the ulnar nerve from C8 to T1. And its path is very important, by the way, and very simple. The pathway will be posteromedial aspect of the ulna to flexor compartment of the forearm, then along the ulnar and passes beneath the flexor carpi ulnaris muscle, then superficially through the flexor retinaculum into the palm of the hand through the Guyon's canal, not the carpal tunnel. It's not in the carpal tunnel, it has its own canal, which is Guyon's canal. Again, take care. The radial nerve is anterior to the lateral epicondyle, while the ulnar nerve is posterior to the medial epicondyle. The ulnar nerve is behind, the radial nerve is in front. And this makes us wonder that the ulnar nerve, at first it becomes behind the medial epicondyle, but eventually it becomes in the volar aspect of our hand, while the radial nerve, at first it becomes at the anterior aspect of our lateral epicondyle, but eventually it supplies the posterior of our hand. So the moral aspect is the posterior, and those who make themselves behind become anterior, and those who make them anterior becomes behind. So be humble in your life. When you become posterior, God will bring you anterior. While if you bring yourself anterior, you will eventually be posterior. Dear great surgeons, take care. The ulnar paradox is very important and very common in EG exam. Injury to the ulnar nerve in the mid to distal forearm will typically produce a claw hand. This consists of the flexion of the fourth and fifth interphalangeal joint and extension of the metacarpophalangeal joint. The effects are potentiated when the flexor digitorum profunda is not affected and the clawing is more pronounced. So, the more proximally sited ulnar nerve lesion produce a milder clinical picture. Again, the more proximally sited ulnar nerve lesion produce a milder clinical picture. And this is the paradox, owing to the simultaneous paralysis of the FDP, the flexor digitorum profunda, the ulnar half, of course. This is the ulnar paradox. Due to the more proximal level transaction of the hand will typically not have a claw hand-like appearance that may be seen following a more distal injury. So the more distal injury, the more clawing, the more bad. The first dorsal interosseous muscle will be affected as it's supplied by the ulnar nerve.